Welcome to another lesson. Today I will discuss about lung abscess. Lung infection that destroys the lung parenchyma, resulting in cavitations, and the central necrosis can result in localized areas composed of thick-walled purulent material called lung abscess. Primary lung abscess occurs in previously healthy patients with no underlying medical disorders, and they are usually solitary. Whereas secondary lung abscess occurs in patients with underlying or predisposing conditions, and most of the time they might be multiple. Lung abscess are much less common in children than in adults comparatively. When we see the pathology and the pathogenesis of lung abscess, a number of conditions predispose children to the development of pulmonary abscess. Those includes aspiration, pneumonia, cystic fibrosis, gastroesophageal reflux, tracheoesophageal fistula, immunodeficiency, post-op complications like after tonsillectomy and adenodectomy, seizures, a variety of neurologic disorders, and other conditions that are associated with impaired mucociliary defense. In children, aspiration of infected materials or foreign bodies is the predominant source of the organisms causing abscess. Initially, pneumonitis impairs drainage of fluid or the aspirated material, and inflammatory vascular obstruction occurs, leading to tissue necrosis and liquefaction and also abscess formation. Abscess can also occur as a result of pneumonia and hematogenous seeding from another side. Primary abscesses are found most often on the right side, whereas secondary lung abscess, particularly in immunocompromised patients, have a predilection for the left side. Both anaerobic and aerobic organisms can cause lung abscess. From the anaerobic bacteria that cause pulmonary abscess, the most common ones are bacteroids, Fusobacterium species, and the Peptostreptococcus species. Abscess can be caused by aerobic organisms such as Streptococcus species, Staphylococcus, E. coli, Klebsiella pneumonia, and Pseudomonas aeruginosa. Aerobic and anaerobic culture should be part of the workup for all patients with lung abscess. Occasionally, concomitant viral and bacterial infection can be detected. Fungus can also cause lung abscess, particularly in immunocompromised patients, but this is less common than that of bacterial. When we see the clinical manifestations of lung abscess, the most common symptoms of pulmonary abscess in pediatric populations are fever, cough, and emesis. Other common symptoms include tachypnea, dyspnea, chest pain, sputum production, white loose, and hemoptysis. Physical examination typically reveals tachypnea, dyspnea, retraction with accessory muscle use, decreased breath sound, dullness to percussion in affected area. Crackles and occasionally a prolonged expiratory phase may be heard on lung examination also. Regarding diagnosis is most commonly made on the basis of chest radiography, and classically the chest radiograph shows a parenchymal inflammation with cavity containing an air fluid level. And a chest CT scan can provide better anatomic definition of abscess, including location and the size. But most of the time, the chest X-ray is enough for diagnosing lung abscess. So as you see on the image, on the first one, there is a parenchymal inflammation with a cavity containing air fluid level on the left lower lobe. And on the second image, there is also a cavity containing air fluid level on the right upper lobe. An abscess is usually a thick-walled lesion with low density center progressing to an air fluid level. Abscess should be distinguished from pneumotocells, which often complicate severe bacterial pneumonias and are characterized by thin and smooth-walled, localized air collection with or without air fluid level. Pneumotocells often resolve spontaneously with treatment of specific cause of pneumonia. The determination of the etiologic bacterial lung abscess can be very helpful in guiding antibiotic choice. Although gram stain of sputum can provide an early clue as the class of bacteria involved, sputum cultures typically yield mixed bacteria and they are therefore not always reliable. Attempts to avoid contamination from oral floral include direct lung puncture, percutaneous or transtracheical aspiration, and bronchoalveolar lavage specimen obtained bronchoscopically. Bronchoscopic aspiration should be avoided because it can be complicated by massive intrabronchial aspiration, and great care should therefore be taken during the procedure. To avoid these invasive procedures in previously normal hosts, empiric therapy can be initiated in the absence of culturable material. Regarding treatment, most experts and the guideline advocate a 2 to 3 week course of parenteral antibiotics for uncomplicated cases, followed by a course of oral antibiotics to complete a total of 4 to 6 weeks. Antibiotic choice should be guided by results of gram stain in the culture, but initially should include agents with aerobic and anaerobic coverage. Treatment regimens should include penicillinase resistance agents active against Staph aureus and anaerobic coverage, typically with clindamycin or ticarcillin with clavulanic acid. If gram-negative bacteria are suspected or isolated, an aminoglycoside should be added. And early CT-guided percutaneous aspiration or drainage has been advocated because it can hasten the recovery and shorten the course of parenteral antibiotic therapy needed. For severely ill patients with larger abscess, or those whose status fails to improve after 7 to 10 days of appropriate antimicrobial therapy, surgical intervention should be considered. Minimal invasive percutaneous aspiration techniques, often with CT guidance, are the initial and often only intervention required. In rare complicated cases, thoracotomy with surgical drainage or lobectomy or even decortication might be necessary. Abscess drainage is reportedly required in only 20% of cases of pulmonary abscess in children. When we see the prognosis, overall prognosis for children with primary lung abscess is excellent. The presence of aerobic organisms might be a negative prognostic indicator, particularly in those with secondary lung abscess. Most children become asymptomatic within 7 to 10 days, although the fever can persist for as long as 3 weeks. Radiologic abnormalities usually resolve in 1 to 3 months, but can persist for years. This is all about a summary of lung abscess in pediatrics. Thank you for listening.